This video lecture is going to cover several different areas of special interest for working with adolescents, and I'm going to start with non-suicidal self-injury. Self-injury, or what is often referred to as self-harm, refers to a variety of behaviors in which an individual intentionally inflicts harm on the body for purposes not socially recognized or sanctioned through culture, and without suicidal intent. So most commonly, these will involve intentional cutting, puncturing, scratching, burning, and self-bruising. Self-injury can be and is performed on any part of the body. Most often it occurs on hands, wrists, stomach, and thighs, and the severity of self-injury can range from superficial wounds to lasting disfigurements and scars. Several years ago, as the DSM-5 was being created, it was proposed that non-suicidal self-injury have its own diagnosis. And the research did not bear that out, so it is in Section 3 of the DSM as proposed criteria for further study. So possibly in the next edition of the DSM, non-suicidal self-injury, or NSSI, will be included as a diagnosis. You can find this on page 801 in your DSM-5 under Section 3. So these are the proposed criteria. I'm going to do a quick overview of them. So in the last year, the individual has, on 5 or more days, engaged in intentional self-inflicted damage through a variety of means, with an absence of suicidal intent. The individual engages in this behavior with one or more of the following expectations: to obtain relief from negative feelings or cognitions, to resolve interpersonal difficulties, or to induce a positive feeling. The self-injury is associated with at least one of the following: interpersonal difficulties or negative thoughts and feelings, occurring in the period immediately prior to the self-injurious act, or prior to engagement in the act, a period of preoccupation with the intended behavior that is difficult to control, or thinking about self-injury that occurs frequently even when it is not acted upon. The behavior is not socially sanctioned, and it causes a clinically significant impairment or interference in one or more areas of functioning for the client, or this behavior is not better explained by or does not occur exclusively during other possible mental disorders or conditions. Before we move on to learn more about non-suicidal self-injury, I do want to bring your attention back to the first slide. selfinjury.bctr.cornell.edu is an excellent resource for information for providers, parents, adolescents, clients about non-suicidal self-injury. There's a ton of information available to everyone, and this is a research center for the study of self-harm behavior. Okay, let's look at some factors in self-harm behavior. Gender. It's often assumed that females self-injure more than males, but there's still not quite enough research to know whether or not this is true. There is evidence to support that males and females differ in why they engage in self-injury and what methods they may use to injure themselves. Socioeconomic status. While there are some parallels between self-injury behavior and eating disorders that have led some to hypothesize that self-injury is most likely prevalent among middle and upper income individuals, there's no existing research yet to support this assumption. We also don't have a lot of research on the impact of race and ethnicity on non-suicidal self-injury. How common is self-injury among adolescents and young adults? So among secondary school or high school and young adult populations, 12 to 24% of young people have engaged in self-injury behaviors. About 25% of youth who have engaged in self-harm behavior report only doing it once in their lifetimes. Studies typically find that about 6 to 8% of adolescents and young adults report current chronic self-injury behavior. Most of these young people are likely to use multiple methods and to injure on several areas of their body. I do want to share a resource that I often show in my in-person classes. It's called The Silent Epidemic. There's 4 parts. It's on YouTube. It's actually a documentary from Australia. It's an excellent documentary about self-harm behavior, assessment, intervention, and treatment. It is quite triggering, so if that's something that would be upsetting or hard for you to watch, please know that going into it. If you go to look for it, I would look for it under The Silent Epidemic, Self-Harm, or Self-Injury so that you find the right documentary. Additional information about self-injury behavior, it often begins in middle adolescence between the ages of 12 and 15, and it can last for a short period of time or it can last for years. For many people and many of my clients, this behavior is cyclical rather than linear, and it stops and starts. So I'll have clients who go weeks or months in between episodes of engaging in self-harm behavior. Some studies suggest that over 25% of those who engage in this behavior report initiating it at 17 years of age or older. So this can occur again at 12, but this can begin in late high school or early college, early workforce. So keep that in mind. Although the majority of college students surveyed report having stopped within 5 years of beginning self-injury behavior, it's clear that for some, this behavior will continue well into adulthood. So why do people engage in self-harm behavior? We can get some clues and information from the proposed criteria for the DSM-5. That reference an expectation of obtaining relief from negative feelings or thoughts, resolving interpersonal difficulties, or inducing a positive feeling state. Many individuals who engage in this behavior also report feeling overwhelmed with negative emotion or emotional pressure. Emotional numbness and sadness are also commonly reported. Individuals engaging in self-injury behavior often report it provides them a way to manage intolerable emotions, or can also give them a way to experience a sense of feeling. And here we have a longer list of reasons why someone might engage in self-harm behavior. Regardless of the specific reason a client might give us, self-injury is best understood as a maladaptive coping mechanism. This individual is engaging in this behavior in an attempt to cope with overwhelming distress, anxiety, depression, despair, or life stressors. Let's wrap up talking about some misconceptions about self-injury. So misconception, all who self-injure are female. Actually, about 30 to 40% of individuals who engage in self-injury behavior are male. Misconception, self-injury is a suicide attempt or a failed attempt. So research underlying the motivations for self-injury behavior shows that there is a distinction between those who are attempting suicide and those who are engaging in self-injurious behavior in order to cope and manage their emotions. So those are 2 distinct motivations and behaviors. Misconception. Self-injury is just attention seeking. So for some people, self-injury is clearly an attention-seeking act. For some people. In this case, it's very important to still honor that intent. If someone is injuring him or herself for attention, then that person needs that attention. This person is crying out for help. In my experience, I haven't encountered this very often. I have had a couple of adolescent females who have presented for therapy for depression, and the initiating act of having their parent make an appointment was realizing that their daughter had engaged in self-harm behavior. And both of these adolescent girls told me once we met alone that they had been depressed for a long time. They were quite depressed, and they had asked their parents about coming to counseling. They asked their parents to make an appointment with a therapist, and the parents, for whatever reason, were reluctant to do so. And in both of these instances, these female clients told me, I finally scratched my arm, I cut myself because I wanted my parents to understand, like, I'm serious, I mean this. I need to go to see a therapist. I want to talk with somebody. I'm in pain. So I have seen it as an attention-seeking behavior, but we never want to minimize any kind of symptomatic behavior, whether it's a suicide attempt or reported suicidal ideation or self-injurious behavior. We never want to minimize that or dismiss that, no matter what the motive for that behavior is. Because even if the motive, for whatever reason, may be attention-seeking, there's a reason for that to happen. The majority of people who engage in self-injury, however, go into great extremes to hide their cuts, scars, and burns. This has been my experience for the most part with many of my clients who engage in self-harm behavior. Misconception. People who self-injure are manipulative. Self-injury is much more about coping, relieving tension, relieving distress, than it is about manipulating other people. Again, while some people may have started the practice as a means of getting attention for whatever reason, very few report that that is the primary reason for beginning or continuing in that behavior. Misconception. Self-injury is untreatable. Although self-injury can be difficult to control or stop, most people who engage in this behavior are able to stop at some point. There is, however, no magic bullet in the treatment of self-injury, as the behavior is most often a symptom of a variety of other underlying issues. Continuing this theme, cognitive behavioral therapy, dialectical behavioral therapy, group and family interventions are all those therapies most commonly used to intervene in this behavior. Psychotropic medications can also help treat underlying symptoms of depression or anxiety. Some who engage in this behavior stop on their own without ever seeking formal support. But because this is often a coping mechanism, the behavior won't stop until the individual has other coping methods and skills available to them to use as alternatives. We're going to shift gears now and talk about bullying and school shooters. So I want to talk about the definition of what a bully is. I'm going to recommend again another movie. I'm going to click over into it real quick here. This movie is called Bully. I share it with many of my classes, and if we were in person, I would share it with you guys, but I can't. I highly recommend it. It is about 8 years old now, but it really holds up. And it's very triggering as well if you have experienced bullying or trauma. There's a lot of discussion about suicide in this documentary, but I believe it's like $3 to rent and $6 to buy on Amazon. So I'm going to play the trailer.
And I think he got to this point where Enough was enough. Tonight, a tragic situation. A Perkins boy, just 11 years old, believed to have been desperate enough to take his own life. This is an awfully complicated and difficult issue. Kids will be kids, boys will be boys. They're just cruel at this age.
Here, what we get is nothing's wrong. We didn't do anything. Everything's fine. They punch me, strangle me, take things from me, sit on me.
Give it to him hard!
He's not safe on that bus. I've been on that bus.
They are just as good as gold. My voice is not going to fall silent. I will go to my grave until a difference is made. We reached out to parents that have lost kids, parents of kids that are being bullied all over the world, and it took off like wildfire.
All it takes is for one person to stand up.
Be the difference. Go out and find that one child, that new kid standing over there by himself, willing to stand up for him. Everything starts with one that builds up. Eventually we have an army. If we all do it together, we will change the world.
One of the reasons I share that video with my classes and why I recommend it is it's a perfect example of everything we're going to cover in this next few slides. So bullying is a specific set of hostile aggression, and it requires 3 factors to be in place. There's an imbalance of power. The behavior is intended to disturb or harm, and the behavior occurs repeatedly over time. Bullies are characterized by the need to dominate others through hostile means and show little or no empathy for their victims. Conflict is different than bullying. Conflict occurs between peers or friends. They're on equal footing, the behavior is not repeated, and the behavior is not necessarily intended to disturb or harm. That is conflict. There's different ways to resolve conflict versus bullying. Bullying is an imbalance of power. So there are very different ways that adults should and can intervene within these 2 different kinds of behavior. Conflict between peers and friends versus bullying between 2 individuals in which there is an imbalance of power. The frequency of bullying is highest in middle school grades. Males are more likely to be both victims and perpetrators. Most recent research indicates that bullies feel more comfortable in the social environment at school, are often moderately popular, and often hold a high status with their peers. 90% of adolescents who were bullied believed that it had caused them significant problems, including loss of friendship, feelings of isolation, and feelings of hopelessness. In research, school personnel not only underestimate the prevalence of bullying that occurs in their schools. When incidents of bullying are brought to their attention, they only intervene in about 1/3 of them. So there's a whole lot of these behaviors that are going on that school personnel don't see or maybe don't want to see. And again, in the bully documentary, there's some excellent examples of school administrators basically doing exactly the wrong thing to intervene. So, interventions. Effective interventions include a school-wide plan with a clear, agreed-upon definition of bullying, a plan of action for handling this behavior. So this shouldn't be one classroom has this policy, the other classroom has that policy. This should be a school-wide intervention plan. Here in Louisville, Jefferson County Public Schools has a district-wide plan, and they have adopted this definition in their policy for bullying interventions. School administration and staff must find a way to eliminate negativity, to create opportunities to recognize pro-social behaviors, recognizing random acts of kindness, and finding a way to recognize and support positive and kind acts done by staff and faculty as well as done by kids. So this goes back to having a school culture that is positive, pro-social, and that is on the lookout for prosocial kind behaviors from everyone, from the principal down to the kindergartners. So reasons why anti-bullying interventions may not work or may have difficulty getting off the ground. Some teachers and administrators have a policy of looking the other way and not seeing bullying behavior, and think about where school administrators underestimate the prevalence of bullying in their school. They're not even aware of some of it that's going on. Intermittent punishment, which means sometimes a bully is punished, there are consequences, but sometimes that bully is not punished, even though the behavior is acknowledged. So there's not a policy of consistently applying those consequences for that behavior. And classroom Darwinism, or survival of the fittest. This belief that only the strongest survive, accompanied by a belief that being bullied somehow makes you stronger or tougher, or is just a part of growing up and being a kid. Okay, I'm going to shift gears now and we're going to talk about school shooters. So for the most part, school shooters have been academically able, white, from intact families, and from middle class or affluent communities. I'll also add they've mostly been male. So if we look at the profile of school shooters, we see moody, confrontational, angry, with low self-esteem. Now, looking at everything we've looked at about adolescent development so far, we see that being moody, being angry are not uncommon mood states and experiences in adolescence. Being confrontational can be a part of asserting one's independence as you go through adolescence. And a lot of us, when we were adolescents, experienced low self-esteem. So this is not a very helpful profile. This pulls a lot of people and doesn't really narrow down to help us identify who a school shooter might be. So let's look at some other factors. So as opposed to creating a profile through mood or internal experiences, checklists have been developed with a focus on warning signs and risk factors. This can be used to motivate schools to develop prevention and early intervention plans, because you can't intervene with every single moody adolescent, but you can identify risk factors and intervene in those risk factors. Checklists are not intended to predict future behavior. Often schools will use them as a profile, and that can lead to unfair labeling of kids, and it can also lead to a sense of false security. So going back to that moody, angry, confrontational, low self-esteem, predicting based on these internal experiences and these common experiences makes it very difficult to identify a specific individual who might behave in that behavior. So that mode of intervention, again, is not helpful and not effective. So prevention should emphasize not who and not when, but should identify the common underpinnings of violence and intervene to maximize protective factors and minimize risk factors. Think back to our suicide lecture. That was a huge focus. What are the risk factors? What are the protective factors? How can I minimize risk and maximize protective factors? So instead of looking for one moody, angry kid, I'm looking for common underpinnings of violence and intervening on a school-wide level. So before we go further, I do want to give you a couple resources for this PowerPoint. An excellent book, Columbine by Dave Cullen. He is a journalist who wrote, he's kind of the authority on Columbine. It's a very thorough review and investigation of Columbine from start to finish. It's an excellent book. I highly recommend it. Additionally, I will recommend the Frontline documentary, The Killer at Thurston High. As we go through these factors in the next few PowerPoints, they're so relevant to this documentary, of a 15-year-old who went to his high school and killed several students and then went home and killed his parents. This is a very triggering, can be very hard to watch, but it's very powerful in helping to understand again what is going on, what are the risk factors for an individual child, what are risk factors in the family, and what can schools do to help. Another documentary about a school shooter would be Raising Atlanta. That's on Frontline PBS, so that's free and available to you streaming. So is The Killer at Thurston High. It's on PBS, that's free. And then finally, I'll recommend, if you Google Susan Klebold, ABC News, you'll come up with an ABC News interview with the mother of Dylan Klebold, who wrote a book about 4 years ago now, and talked about her experience in raising Dylan Klebold and in learning that he was one of the shooters at Columbine. And there's a lot of interviews with experts on school shootings, as well as an interview with a survivor. So that's an excellent resource to get a better understanding of what may be going on with these adolescents. Targeted intervention. So here we are not looking for specific individuals that are experiencing sadness or anger or moodiness. We're looking for ways to intervene with individuals who are experiencing these problems. So many school shooters do not have a diagnosable mental illness, but many have reported feeling extremely depressed and have either threatened or attempted suicide sometime before the shooting. So this is where school-based therapy could help. Offering intervention services in the school for depression, anxiety, and so forth. Aggressive hate towards self and others. So this looks like a combination of narcissism and low self-esteem, self-loathing, and the belief that they are different from their peers. Most school shooters have exhibited disturbing behaviors which showed a callous disregard for the lives of others and for themselves. So this information will not help us identify a specific school shooter, but it does let us know where we can intervene within our school. A very, very important factor in school shootings is planning and leakage. Very rarely are these events impulsive. 77% of school shooters have developed a plan at least 2 weeks in advance. Leakage. This occurs when a student intentionally or unintentionally reveals clues to feelings, thoughts, fantasies, etc. that may signal that they're going to engage in a violent act. Very often shooters told one or more person about the plan, sometimes detailed and sometimes vague. If you watch the Killer at Thurston High video, you'll see them interview some of that child's peers who say, oh yes, he said this, he said that, he said don't come to school tomorrow, something bad is going to happen. So most leaking occurs in verbal communication, is repeated over periods of time. Those who learn the plans often did not pass this information on to adults. They dismissed it as complaining or maybe even bragging. They dismissed it as just talk. So there's been a big push, a big intervention to get adolescents, to get kids to report these kind of leakage occurrences when they happen. So the fourth factor is a vigilante motive. The most common motivation for school shootings is revenge, for a real or perceived grievance. Often, no one event alone caused the school shooting. Rather, school shooters described multiple experiences of being bullied or feeling as if they were persecuted. They reported not feeling safe at school and not feeling that adults could or would keep them safe at school. Finally, interventions. Caring adults. Interventions on the peer level to increase interpersonal support and interpersonal connectedness. Better ways to express anger and other distressing emotions. Behavior management in school. And communication within the school, communication between the school and the community. If you read the Columbine book, there was a complete breakdown between communication with the school and communication with the law enforcement in the town leading up to the school shooting. Finally, we're going to look at sexual behavior in adolescents. This is a lot of research and stats, and it's all very important. I'm going to let you guys review it yourselves. It's important to know if you're going to be working with adolescents, you're going to be talking about sex. So in 2017, 42% of females and 44% of males aged 15 to 19 had sex. So that's almost half of our high school aged clients. Virtually all sexually experienced female teens had used some kind of contraception, most often a condom. In 2017, a nationwide survey found that 85% of students, grades 9 through 12, identified as heterosexual, about 2.5% identified as gay or lesbian, about 8% identified as bisexual, and about 4% were not sure of their sexuality. In 2017, babies born to adolescent girls ages 15 to 19 accounted for about 5% of all births. So our teenage birth rate has been declining dramatically over the years. And I'll go ahead and pop us up to the next slide for the graphic. So between 1990 and 2017, you can see a remarkable decrease. However, having said that, we still have the highest teen birth rate in the world compared to other developed countries. 1 in 5 people diagnosed with HIV in 2018 were adolescents. Minority teens are heavily overrepresented in HIV cases, with the most being represented by African American adolescents, followed by Latino adolescents. Adolescents are the higher risk for contracting an STI or a sexually transmitted infection because they have a personal fable, which is nothing bad can ever happen to me, the practice of engaging with multiple partners, and the sporadic use of condoms or other forms of protection. So about 25% of an STI every single year, but only 12% of adolescents are aware of how common STIs are. Only 12% of those adolescents know that 20% of all Americans have an STI. And HPV is the most frequently diagnosed STI among adolescents. It's very important to be able to provide psychoeducation about safe sex, about protection, about risk factors, about STIs to adolescents. So here I provided a great deal of information, for instance, about HPV, which is a particularly scary infection because you can have it for a long time without having any symptoms or any signs that there's a problem. So HPV can cause cervical cancer and other cancers of the genitals. It also causes cancer in the back of the throat and is the cause of most mouth cancers diagnosed in the United States, even among adults at this time. So those are the kind of information and facts that you're going to want to be able to share with your adolescent clients, not to scare them, not to threaten them, but to just provide them with as much information as possible to help them make good decisions. So protective factors in adolescent behavior. A delay in sexual activity is associated with close relationships with parents, parental disapproval of adolescent sex, and a close mother-daughter relationship. The same protective factor was present for suicidal behavior. Strong family connections, strong family relationships. It does not say that adolescents who have a close relationship with their mother or with their parents don't have sex. It says they delay the onset of sexual activity. And if and when they have sex, they're more likely to use birth control and to practice responsible sexual behavior. One of the biggest risk factors in adolescent sexual behavior is a lack of education about sex, and that often parents do not want to engage in in-depth discussions with their kids about sex. Effective sexual education programs are ones that emphasize both abstinence and safe sex. Even effective programs don't keep kids from having sex, but they again delay the onset of sexual activity, and they also increase the likelihood that adolescents will in responsible sexual behavior.